The broadcast is now starting. All attendees are in listen-only mode.
Good morning. We're going to go ahead and get started this morning. Welcome everybody to Friday Medical Conference sponsored by Western Montana AHEC, Area Health Education Center. I'm Darren Bell. I'm one of the faculty with the Family Medicine Residency of Western Montana. And today I am pleased to welcome you all to listen to a presentation by Dr. Cassandra Lopez. Cassie was born and raised in Woodstock, New York, where she got her undergraduate degree, and then she moved to New Mexico for her medical school training. She, in New Mexico, experienced different cultures and populations that developed in her a love for public health, and subsequently she decided to move to Western Montana, to Missoula, to pursue her residency training. She's now a third-year resident and one of our chief residents in our program. While here, she has helped to revamp, invent, create our addiction services program for our pregnant patients here. And after she gets done after she graduates this spring, she'll be pursuing a fellowship in obstetrics in New Jersey. After that, she and her husband planned to move to Lewistown, Montana, where she hopes to continue to provide comprehensive primary care as well as addiction services for patients and population of central Montana. So with that, let's all please welcome Dr. Cassie Lopez.
Thanks, Darren. Everyone hear me okay? For those of you here this morning at St. Pat's, thanks for braving the weather. That was quite a shock to me when I opened my front door this morning. So the title of this presentation is Addiction Medicine from the Primary Care Perspective. I apologize for the pun. It was right there. I had to use it for my presentation title. And as Darren alluded to, when I was in New Mexico, I got really interested in addiction medicine, and I've continued that training during my residency here. And as I was going through my training, I noticed that I was fielding the same questions from similar sources pretty consistently. And that was the impetus for this presentation, was for me to take my experiences and my perspective on treating addiction and share it with everyone here. So I guess a better title would be from the perspective of one primary care physician. But I hope you guys find this presentation useful. And it does say primary care, but I think a lot of what I'm presenting today is applicable to every specialty in medicine, plus other non-physician specialties as well. So a few disclaimers before we get started. I don't have any financial interest. I do have a very personal interest in this topic and an ethical interest, so that's my bias. We all have ours, so mine's out there up front. I'm not board certified in addiction medicine. I'm actually technically not board certified in any specialty currently. Hopefully in July that will change. And so, what I have to share with you is the research of others that I've put together. And so I am by no means an expert on this topic. This presentation does cover just select topics involving addiction medicine and primary care. There is such a large body that I could have pulled from. I tried to pick the things, like I said, that in my own personal experience seem to be the most common questions and concerns that I had raised to me. And I want to encourage this to be somewhat interactive. I know that this is a topic for people that can bring up a lot of emotions. And so what people share today, I would just like everyone to be really cognizant of respecting all the opinions that you hear. So the objectives here for our presentation, we're going to briefly review the definition of addiction and the current literature on the pathogenesis. And then we're going to spend the bulk of our time today reviewing addiction as a chronic medical condition, exploring the stigma surrounding substance use disorders, and then interwoven throughout this is what we can do as primary care providers and, like I said, as all specialties in medicine. Does anyone know who said this quote? It's of someone famous. If you want to waste a few hours, trust me, just try Googling quotes of famous people on alcohol. This is actually Frank Sinatra. So before we get into the presentation, I think it's important that we all have a similar working definition of addiction. So these are the more descriptive definitions versus the more diagnostic definition of substance use disorder. I chose these two in particular. One is from the American Society of Addiction Medicine, and the other one is from actually an author of a paper that I found, and I really appreciated his descriptive definition. And I chose these because they highlight some very important points that we need to keep in mind going forward here. And one is that this is a chronic disease of the brain. It involves memory, motivation, reward, and it manifests itself in very characteristic ways. And I liked the second definition here because it highlighted a few things. One, I liked the terminology when they called it a maladaptive neuroplasticity. So it's an adaptation, but it is not a helpful or beneficial adaptation. And I very much like the fact that they pointed out that this occurs in vulnerable individuals in response to a repeated exposure to drug of abuse. Something I think is also important to remember is that these circuits affect not only internally how a person functions, but it also affects every aspect of their functioning in relation to the external environment. So relationships with family, relationships with friends, ability to remain employed, their interaction with the criminal justice system, and what we're going to focus on today here, it also very much affects the way that they interact with the healthcare system and medical professionals. So I wanted to review briefly the spectrum of substance use, so talking about not just substance use disorders, but newer terminology that's starting to come out. These are terms that I pulled from the American Society of Addiction Medicine and SAMHSA, and these are the new proposed terms to replace a lot of the older terminology that we had used, such as substance misuse, substance abuse, substance dependence. And so this is now what they would like us to adopt as the spectrum of use out there. So unhealthy use is any use that you can see here that increases the risk or likelihood for health consequences. So I think this is pretty much all the idea we have in our head of most college students in America that are binge drinking on the weekends, haven't had any negative health consequences yet, but are certainly putting themselves at increased risk for this. Harmful use is use with health consequences in the absence of a substance use disorder or addiction. So you can think of this as a patient you're seeing that has already had an episode of acute alcoholic pancreatitis, or even a patient that's contracted HIV or hepatitis C, but they don't have a diagnosis of a substance use disorder. And then as you can see here, the substance use disorder, so it's recurrent use of alcohol and or drugs, and it causes clinically and functionally significant impairment. You can find the criteria online. I didn't list it up here today because it's readily available for everyone to see. But the new classification for substance use disorders is either mild, moderate, or severe based on the number of criteria they meet. And most of these criteria, as the definition suggests, involve significant impairment in all facets of a person's life. So again, forgive me for the puns that will be throughout this presentation. A fallacy I wanted to address when it comes to addiction is that the crux of it is not on frequency or quantity. What really makes addiction unique is a qualitative relationship that a person has with whatever substance that they have it with. So this has to do with the way that a person reacts to any exposures to that drug. So the sight of it, the sound of it, stressors, environmental cues. We know from functional MRI studies that people will have characteristic activation in certain brain centers when they even hear a sound associated with their past use, or that they are given an environmental cue such as the smell associated with it. It leads to preoccupation and obsessive pursuit here. And these things persist despite the accumulation of negative consequences. Oftentimes, I think this is where we, as people who might not have a substance use disorder, tend to struggle. Because objectively, we see the negative consequences, and we often wonder, why is it that someone continues to follow a certain pattern when we can see that they are having extremely negative consequences? And this really is the underpinning of substance use disorders and addiction. And so something I think that we need to maybe accept as providers, or anyone that's having contact with someone with a substance use disorder, is that if we don't have personal experiences with this, this is something that we might not ever really be able to understand. But luckily, I don't think we necessarily need to understand it in order to be able to care for these patients. And so how does addiction start? If you look through the literature, which I spent a lot of hours doing, there is a new model out there that's being proposed. And so it's a two-stage model or multi-stage model. And it has a name. It's called the Causal Common Contingent Model, or CCC, if anyone decides to go and do some extra reading on this. And this model really tried to explore substance use as a spectrum. So looking at initial substance use and then progression to problematic use or substance use disorder. I don't really like the term problem use or problematic use, and it's not technically one of the medical terms we should be using, but it is the term that's used in the literature a lot, so just for clarity's sake, I'll be using it throughout the presentation here. And what these studies have tried to explore are, number one, what are the various influences on initiation of substance use and progression to a substance use disorder, and do those things overlap? How much do they affect one another? What they have seemed to find is that initial use, so whether or not someone ever has any lifetime use of a given substance, or meaning illicit drugs or alcohol or tobacco, has to do probably more with environmental factors than genetics. So these are things like the cost and availability of this substance, where someone's living, peer pressure, societal acceptance, someone's religion. If someone grows up in a very religious household, chances are they're not going to have the exposure to certain drugs or alcohol. And so they may never actually initiate substance use. Therefore, without that initiation, they can never develop a substance use disorder. And so many people we know that initiate substance use don't go on to develop a substance use disorder. So what makes certain people more vulnerable than others? Well, to answer this question, they have done mostly twin studies. And usually what they've done in these twin studies is looked at dizygotic twins versus monozygotic twins. Occasionally, some of these studies have looked at twins that might have been separated at birth, but since that's not extremely common, the previous model I mentioned has been used more often. This is one study I chose for a few reasons. One, I liked that it had a very large sample size. So this study was done in the UK, and they had over 1,200 pairs of twins that responded to the surveys they sent out. And this was roughly split in half between monozygotic and dizygotic twins. And they wanted to explore two concepts here. So they really wanted to explore the concept of heritability, and then they also wanted to look at something I talked about on the previous slide. They wanted to look at how much overlap is there between what causes someone to ever use a substance and what causes someone to progress to a substance use disorder here. So if you remember back to high school biology, the concept of heritability essentially means what is the proportion of variation in a given trait that is not due to random chance alone. So likely has some genetic influence or underpinning. If you look at this study here, the way that they separated this out was this category here. They used these coefficients and these labels. So A2 are environmental, shared environmental factors. C2 are genetic. And then E2 is a category that they use called unique environmental factors. So this was maybe something that one twin in the pair had experienced and the other one might not have experienced this environmental factor. And they did this for alcohol, cigarettes, and marijuana. And for alcohol, what they defined as progression of substance use was greater than 10 drinks in a week, and for cigarettes was greater than 6 cigarettes in a day. And in the UK, they actually looked at a slightly younger population than we would consider here because the drinking age there is 18. So they surveyed people between the ages of 14 and 18 there. And so what they found here, make sure I don't mess anything up. Okay, ooh, it worked. So if you look, oh, actually, I think I had these backwards. So this one is genetic and this is environmental. So if you look here, the higher coefficient here is underneath the shared environmental influences for alcohol use. This was an extremely complicated statistical analysis they used, and we can talk a little bit about the flaws involved in these types of twin studies later on here. But essentially what their statistical analysis based on the survey results showed was that if you look at the initiation and what caused people to ever use a substance, so it was just a yes or no answer. Have you ever used this or have you not ever used it? Had to do with shared environmental factors that these twin pairs had. When they did a complicated statistical analysis to look at progression, they found that actually when you looked here, it was mostly genetic influences. There was almost no component of shared environmental factors, but there was this large component of unique environmental factors for somebody. So we think of these often. If you guys came for Dr. Mentel's presentation a few weeks ago, these might include a lot of those adverse childhood events that we're starting to pay attention to more and more here, that were not shared among the twin pairs, but maybe unique to each individual person. This beta coefficient was, again, the very complicated statistical analysis they used to see if somebody ever started using a substance, how much overlap was there in whatever caused that initial use, and then what caused their substance use disorder or their problematic use. And if you look here for alcohol, this was actually fairly high. So there is a lot of overlap between why someone ever drinks in their lifetime and what causes them to develop a substance use disorder. What I found incredibly interesting is it was actually even higher for marijuana and for cigarettes. So if you look at these two, perhaps if we're designing some public health campaigns, it shouldn't be meth, not even once. It should be cigarettes, not even once, because the factors that cause someone to smoke a single cigarette are often what cause them to develop a substance use disorder. This is another graph just showing a multitude of other studies that have been very similar here. So this was pulled from an article that looked at, and if you look up here, this one, I don't know if anyone's familiar with this, Virginia adult twin study. There was also a Vietnam era twin study, and this one actually did look at twins that were separated at birth due to war trauma. And this was a National Swedish Register, and then the one in yellow here is a meta-analysis that combined many, many other twin studies. And here they chose to describe this as a heritability index, which is very similar to the statistical numbers that we just looked at. But they tried to take heritability and put it on a spectrum. So a heritability index of 0 means that the expression of a trait is pure random chance and environmental influence. A heritability index of 1 means that it probably is 99.9% genetics. We know that there is basically no trait out there that does not have any environmental influence, but a heritability index of 1 shows that the majority of that comes from common genetic material. And so if you look here, the numbers do vary between the studies, but there is this overall consensus that there is certainly a genetic and heritable component to substance use disorders. And so why do we think that there's a difference between what causes people to ever use a substance and what causes a substance use disorder? Well, the theory out there is that probably during adolescence, people are more susceptible to parental influence and to the common environmental influence from their very shared world that you live in as a young adult. Oftentimes you're more sheltered, and oftentimes you do rely on the rules of the household you're in, maybe the small religious community you're in, and maybe whatever culture at large that you're in. But as we get older and we break away and we have more autonomy and freedom, our actions are more likely to reflect our own genetic predispositions and our own propensities for certain behaviors or actions. We know from the study of teen pregnancy that teenagers do not always listen to their parents. But in general, I think that parents here can feel assured that it seems that your kids actually do listen to you when you tell them not to drink or do drugs. And so why do genetics affect the phenotype of addiction? How and what way does this happen? Well, there are a few different theories here. One theory is that perhaps the genes that seem to make people vulnerable to addiction code for certain personality traits that make one more susceptible. Impulsivity is something that's being studied a lot now in the literature, and they're also using twin and sibling studies to see how somebody who might have more impulsivity might be more susceptible to a substance use disorder. Another theory out there is, does this have to do with a physiologic response that someone might have to a substance? We actually already know that there are several genetic examples of that. So if you look at Chinese and Israeli males, we know based on genotyping that they have a much higher rate of being homozygous for an altered level of activity of alcohol dehydrogenase, which affects how people are able to metabolize and process alcohol. And if any of you have had a friend that's either Chinese or Israeli, you might have seen them drink and develop a really incredibly unpleasant flushing sensation that they do not like. And so if we look at these populations, the rates of alcohol use disorders are actually much lower than if you look at worldwide in these specific ethnic populations. And that makes sense. If you drink and it causes you to feel very uncomfortable and it causes a really negative physical reaction, chances are you're hopefully not going to be drinking again. That was the whole impetus behind developing disulfiram as a medication to help with alcohol use disorders. If that is true, if we know that there are genetically programmed negative reactions, it would make sense that there's likely also genetically programmed positive reactions. Potentially that there are people out there that, due to their unique combination of genetics, are physiologically programmed to respond very positively to certain substances. They might experience a heightened sense of euphoria or whatever positive feedback they get compared to the general population. And that certainly would put them at risk for seeking out that stimulus again to experience whatever reaction they had. There's also this concept of epigenetics, which again, hopefully if some of you came to Mark Mantel's presentation, he covered on that a little bit. And again, if you remember back to maybe in high school you covered this or in undergrad. So epigenetics is modification of genes that does not have to do with actually modifying the base pair or the sequence, but it's modifications like methylation or histones that do cause altered gene expression without actually modifying your genetic material. And so this is really just starting to be looked into when it comes to addiction and substance use disorders. Are there perhaps life events or environmental stressors that cause us to start modifying certain gene expression, which makes us more susceptible to substance use? And more interestingly, are these epigenetic modifications actually heritable? Do they affect gamete cells, and are these passed on to future generations? So potentially, that means that certain very traumatic environmental things or just traumas in general are actually heritable. I really liked this quote. This was from a paper I found. And essentially, this just means we don't know. There's a lot more research that needs to be done to really see what the ultimate outcome is going to be and what clinical relevance all of this research is going to have. Does anyone know who said this quote? I very much like this one. It's actually Benjamin Franklin. We can tell he liked his beer and wine. So now we're going to segue into the more sort of clinically oriented portion of our talk today. And this is really focusing on addiction as a chronic disease. So we know now that addiction is widely recognized as a chronic disease. It often follows a relapsing and remitting course, similar to many other chronic diseases we treat. However, most medical schools and residency programs still have very minimal education on addiction. Patients still feel marginalized and stigmatized when they seek treatment, and many providers fail to either screen for substance use or fail to recognize the signs of hazardous use or substance use disorders. Why is there still such a large disconnect in the medical community between the research coming out, the formal recommendations of many professional societies, and our clinical practice? A lot of it has to do with the way we still feel about addiction and the way we still view it. And there are numerous qualitative studies out there that have looked at just this. One study I found involved ER physicians and their rates of satisfaction with different patient encounters throughout their shift. And it found that they had consistently higher dissatisfaction rates when they had encounters with patients with substance use disorders compared to other chronic diseases that we all see as having a large behavioral component to them, such as COPD, such as chronic low back pain in patients with obesity. We know based on survey data that healthcare professionals view drug addiction much more negatively than mental illness. The exception to this, and to actually most of these things in general, was that mental health professionals, way to go guys, still they tend to view addiction as equal to other chronic diseases. Providers feel more positively about a patient with a substance use disorder if they see them when they're in active recovery than when they're actively using. I actually caught myself thinking, yeah, that's actually true. I think I have that bias as well, and that was something that I learned from this presentation. And we know that actually the more contact someone has with treating substance use disorders, the more positive their attitudes tend to be. Also, interestingly, physicians that had a personal history of substance use had much more positive attitudes towards patients with substance use disorders. Maybe some of this has to do with our training, unfortunately. There was a study from Israel that showed that medical students in their preclinical phase of training, so before they had much patient encounters, actually felt more competent treating substance use disorders, and they had less of a sense of moralism about the topic in general than when they actually entered their clinical phase of training. And that actually made me quite sad when I read that study, and I just asked myself, what is it about their experiences out with patients that actually caused them to change the way that they felt? I think it could be a number of things. It could be system-wide issues that we still experience. I mean, how many people here have come up against systematic barriers when treating substance use? Just a raise of hands here. Right? A large portion of us, we experience barriers and frustration with the system. Maybe it was the prevailing thoughts on substance use disorders amongst the higher level physicians that were helping to train them. Regardless of what it is, we know that providers often report a sense of powerlessness, frustration, and resentment when it comes to treating addiction. Less than 20% of primary care physicians actually feel prepared to identify a substance use disorder. I think we all have this vague idea of what addiction is and probably what a substance use disorder is. The newer DSM criteria are really helping us to hone that down, but there's still a gap in our training where a lot of us actually are not given the tools to identify this. What I found most interesting and perhaps a little bit disturbing when I was going through all of this literature is that in general, when you poll healthcare professionals, we actually have a very low level of knowledge and education about substance use disorders. And so we have this negative stigma, but we actually don't know that much about the subject that we tend to feel this strong negative reaction towards. And if you look at the literature, we know that if we provide additional training to physicians, their attitudes change. They become more positive and they feel more engaged in treating patients with substance use disorders. This is part of what I'm hoping to accomplish today, is provide a little bit more background and information for people and help them just feel perhaps a little bit more positively and a little bit more engaged. So this part, I would like everyone to participate if you feel comfortable. And I would just like anyone to share what is it that stopped them from asking somebody about substance use, or what in particular has frustrated them when it's come to treating a patient with a substance use disorder. Exactly. What do I do if they tell me, yes, I'm drinking 20 beers a day? Oh, sure. Somebody just said they don't know what to do with the answer, or they don't have time to deal with a positive answer or a positive screen. Yeah, somebody said that they don't have enough resources. Absolutely. Yeah, somebody else just said they worry about patients being honest. We feel that patients lie to us. Absolutely. Yeah, so someone just said you worry about offending a patient or affecting their relationship if you broach the subject of substance use with them, right? It sort of feels like a taboo subject, and you feel that simply mentioning substance use to another person would offend them on a deep level. Absolutely. Well, thanks guys for sharing. So, I mean, you guys hit on a lot of the things that have been mentioned time and again in the literature. So the lack of adequate training, I think, goes with what Ned said about not knowing what to do with the answer. We don't really have the skills and the tools available. We're not really taught what to do if somebody says, yes, I am using. We're skeptical sometimes about the treatments, if they work or not. We have discomfort discussing substance use with another person, with a patient. We question people's integrity, and we maybe assume, or maybe we know from vast personal experience, that patients often lie. There's time constraints. So again, you don't have time. If somebody says, yes, I'm using, what do you do with that answer? There's perceived patient resistance. So if somebody says, yes, I'm using, and you try and talk to them about treatments, a lot of providers feel like patients are going to say no, and they're going to be resistant to talking about treatment. And then there's the ever-present reimbursement concerns. If I spend 20 minutes in a patient room counseling them about substance use, am I going to get reimbursed for that time that I just spent there? Yeah. So I didn't actually run across any data that looked at if that changed, but certainly if you look at the studies that they poll patients on why they're not honest with providers, one of the most commonly cited reasons is they feel stigmatized and judged. And so they feel hesitant to be honest with us. So I absolutely think it might be a sort of, chicken and the egg, or this vicious circle we get in. If we feel negatively and we project that, we're going to continue to experience the things that make us feel biased because of that. So why do we have all of these feelings towards substance use? Well, this is really kind of the meat of the presentation and what we're going to spend the rest of our time focusing on here. Again, this is not a comprehensive list. I chose to focus on these specific negative feelings towards substance use disorders because in my conversations with people, these would most often be the things that people would express to me and say, you know, I just haven't really gotten into treating patients with addiction because of X or because of Y. So I apologize if I gloss over anything that people here thought would be important, but for the sake of time, I chose to just focus on these few things. So we're going to talk about the first one here, and this is probably a ubiquitous thought that everyone in this room has had at some point, including myself, right? We have this deeply ingrained belief that addiction is a choice. We're taught to basically see drug use as a voluntary and hedonistic act. And so we're often frustrated when we ask, why can't people just stop using? And so what about the concept here of personal responsibility? Well, before we get a little bit more deeply into that, I want to just look at the US population as a whole. So the top left graph here, if you look, this is asking about past month illicit drug use. So this was a nationwide survey. And if you look over here, the number of people in millions, so this is all age groups 12 or older. How many people in the last month have ever used an illicit drug? It's over 28 million Americans in a given month will use an illicit drug. What that equals is 1 in 10 Americans per month will use a drug. Because if you see here, that's about 10% of the population. 1 in 3 Americans have drank alcohol in the past month alone. If you look at lifetime use, 50% of Americans age 12 and older have ever used an illicit drug. So if you look to your left and to your right now, somebody sitting next to you has probably ever used a drug in their life. Perhaps it's you, we won't tell. But this, I think, illustrates a super important point. 86% of Americans over the age of 18 have ever used alcohol. Drug and alcohol use are the majority in this country. It's not the minority. Drug and alcohol use are ubiquitous in our country. But when that use becomes a significant issue in a person's life, we then tend to view them suddenly different than the rest of the population. Many people here use a beer or a glass of wine at the end of the day to relax. If we didn't get some sort of positive benefit from alcohol and drugs, they wouldn't be as popular as they are, as we can see here. We don't really seem to judge occasional use for stress relief or occasional use for some alteration of brain chemistry. But once someone is past a certain level, they suddenly become an addict in our minds, and they become very separate and different from us somehow. As soon as someone is no longer functional due to their substance use, studies show that we have a negative attitude about them. But the irony there is that as soon as that happens, they need the medical system to get treatment to again become functional. Without that compulsion that defines a substance use disorder, they wouldn't need our help. We seem to commend the people who don't need the medical system to not use drugs and alcohol, and then we paradoxically stigmatize the people that do. It's the ultimate catch-22. And I think if we just simply recognize that we might have this inherent bias and these thoughts about personal responsibility, we can move past those and we can begin to really focus on the bigger picture of addiction. The next concept here to talk about is relapse, right? So relapse feels like a very dirty word, I think, a lot of times when it's mentioned. It's most often applied to addiction and to substance use disorders, but actually the definition of relapse is very broad and does not mention drugs or alcohol at all. So if you look it up, the definition is simply a deterioration in someone's health after a temporary period of improvement. Doesn't sound so bad, right? So why do we feel very negatively about that word relapse? Well, luckily someone much smarter than me has already looked at relapse in a much broader sense in the context of other chronic illnesses here. And if you look at the graph, sorry, it's a little blurry, it shows the average rates of relapse in a given year for multiple chronic diseases here. And if you look at these, I mean, for example, look at hypertension and asthma, 50 to 70%. If we take that top number, what that means is that sustained remission is actually not the most common disease state here. Sustained remission is the minority. This means that most people with hypertension and asthma are in varying states of relapse throughout the year. And here at the bottom here, I just showed in this study, they defined relapse as a symptom recurrence to the point where they required additional medical care to reestablish symptom remission, which is similar to the initial definition of relapse that I talked about. And I think relapse is an important concept because this also brings up the concept of adherence. You're welcome, Tim Caramore. So if you look at adherence across the board with multiple chronic medical conditions, this is not unique to substance use disorders. If we just simplify sort of adherence when it comes to addiction or a substance use disorder, that would basically just mean somebody not using that substance would mean that they are being adherent to whatever treatment we prescribed for them. If you look here, less than 60% of patients with type 1 diabetes fully adhere to their insulin. This is a disease process with significant consequences of non-adherence, such as DKA, such as early mortality. But if you look at that number, there's a large portion of patients that struggle to adhere to their insulin. It's the same thing with asthma or hypertension. I think that third bullet point probably hits all of us primary care providers really hard to know that less than 1 in 3 of our patients are actually taking our dietary and physical activity recommendations to heart. So is perfect adherence essential to obtain a clinical benefit? I think that this is an extremely important question for us to briefly touch on today. This is often, I think, where the sense of our frustration comes from when it comes to non-adherence. You know, why can't patients just simply follow this? They'll be better off. But what if they do follow our advice, just not 100% of the time? They can still get huge clinical benefit here. Even short periods of sobriety can decrease someone's exposure to transmissible diseases such as HIV and hepatitis C, can reduce other risk-taking behavior, can actually have consequences and reduce long-term mortality if they are able to be sober for even the brief periods of time. If a patient is not perfectly adherent, I think we often will feel that we failed. Or sometimes we feel a sense of frustration at them, like they failed. But I think we just have to remember that the struggle of adherence is the struggle of being human. We all have these higher order brain functions and these rational thoughts of things we know are good for us and things we know are bad for us. But these clash on a daily basis with our emotions and our urges. So moving on here to treatments. This is definitely one of the things that when I've talked with people, they've been very skeptical about. I mean, all we have to do is look at the last few decades of medicine to see numerous examples of medications and treatments that we were actually fairly wrong about. And so I think skepticism is very healthy. When talking about the treatments going forward here, I'm mainly going to be focusing on medication treatments because that is my area of training and expertise, although I will touch very briefly on counseling. And so again, the problem here with treatments is that we don't have a lot of training on them, and so people don't feel very comfortable with the treatments, and they often ask me, do they work? Well, the answer is yes and no, like most things. It's complicated. We know that we have very effective treatments. We also know that there are very big flaws right now in the way that the healthcare system has set up our treatment models for addiction, and these in themselves can lead to very big treatment failures. So let's just start with the very basic things. Don't forget that you as people actually have a lot to offer. Often the biggest treatment benefit is just regular contact with the healthcare system. There's a study I found that I liked because one, it was a fairly large sample size, and two, I liked that it was 15 cities. So it sampled a lot of major metropolitan areas across the country and had a pretty diverse diverse range of patients included in this. And so what they did is they just looked at clinics that provided HIV testing, and they did either usual care, which was HIV testing for patients when they came in and asked for it, or HIV testing, plus they signed up a small subset of patients for 3 motivational interviewing sessions. At the end of 6 months, I think the results here were pretty remarkable. It was less than half the rate of injection drug use. People were 4 times more likely to actually be not using any substances confirmed by UA, and they also had lower arrest rates. 6 months probably seems like a short amount of time here to a lot of people, and they say, well, that's just short-term benefit. What about the long-term benefit? I would argue that actually if you're able to reduce someone's amount of injection drug use over 6 months, you are probably preventing a number of cases of HIV or hepatitis C or other health complications. And you are probably doing a lot of downstream good here with even just, like we talked about, just short-term periods of sobriety. There's a second study I liked here where they looked at prenatal women that came in for care, and they screened positive on their first routine urinary drug screen for cocaine. And they either had standard prenatal care or they were sent to 1 week of inpatient treatment, and then they had twice weekly counseling sessions after that. And very similar results here. By the time of delivery, 50% less women in the treatment group tested positive again for cocaine. And their infants had higher birth weights, and there were much less NICU stays. So, I mean, how many interventions can people easily think of here that have a 50% about relative treatment benefit and essentially no harms, no negative outcome, like nothing negative that can really happen from the treatment? We can't really come up with a lot of examples of that easily in medicine. These are very simple, low-cost interventions that even primary care providers can get trained on in motivational interviewing and can actually bill for and get reimbursed for. And they can have huge savings when it comes to quality-adjusted life years, as well as when it comes to prenatal care, to huge healthcare dollars down the road. All right, now we're going to get into the medication portion. So briefly touching on alcohol use disorders. These numbers were pulled from a very large meta-analysis. And if you look at these, so these are the most common medications that we're all familiar with. I think probably naltrexone is the one that most people are familiar with in the last decade that's been used most often. So if you look here, the numbers needed to treat are actually fairly good for these medications. 20 to prevent any return to drinking, and 12 to prevent return to heavy drinking. Some of you are not going to be surprised that I added a little bullet point here on the fact that actually injectable naltrexone was not associated with any benefit here. This was all oral. And then acamprosate, I think we would all be surprised to find out that acamprosate is actually the most effective drug out there for the treatment of alcohol use disorders. And then disulfiram actually does not have any evidence associated that it prevents people from drinking. And I think we all probably intuitively know that that's because the adherence is not great, because people don't like to feel sick when they take this drug. So one inherent limitation here is that, again, these studies are usually only for about 6 months at a time, most of these randomized controlled trials, so we don't have a lot of long-term data. And secondly, something I think is a huge oversight is the fact that most of these studies on alcohol use disorders did not look at any other secondary outcomes. They simply looked at rates of drinking. They did not look at mortality, other health conditions, or even arrest rates that some other studies have looked at. And so I think that that's a big hole in the literature itself that I hope will be addressed eventually. So opioid use disorders. Again, I'm going to focus mostly on medications here because this is really where the bulk of my experience comes from. So when we use any medications to treat addiction, the blanket term that we use is medication-assisted therapy. However, this term usually gets applied to opioid use disorders, although the particular term for using a medication to treat an opioid use disorder is opioid replacement therapy, or ORT. So you might see that acronym in here as well. Methadone and buprenorphine are really the two main FDA-approved drugs right now to treat opioid use disorders in this country. The mortality data on methadone, I was actually even surprised on when I looked it up, to be honest. It can have up to a 50% reduction in mortality in patients with substance use disorders. It decreases rates of HIV and hepatitis C. People stay in treatment programs longer, reduced crime. We know that these effects are greater than placebo. And the WHO actually lists methadone as one of their essential medications, which I was surprised by that finding as well. Some people here may have a strong reaction to hearing the data about methadone and be a little bit skeptical. I think, unfortunately, methadone in particular has a very negative stigma around it. And that is for cultural and historical reasons, I think, and other forms of bias, such as racism, unfortunately, do play in here. It also has to do with the fact that, I don't know if many people here are aware, but methadone can only be dispensed out of a federally licensed facility. So it's not available through routine healthcare providers. And that keeps methadone and opioid replacement therapy up until recently very separate and sort of, segregated from the rest of the medical community. And that really maintains this shroud of mystery and sort of perpetuates that negative stigma. I mean, even the term methadone clinic oftentimes has a very negative connotation attached to it. The second medication, and the one that I have the most experience with, is buprenorphine. So for those of you who aren't familiar with buprenorphine, it's a partial opioid agonist. So it binds to the same receptors, but it will not stimulate them to the same point that a full opioid agonist, such as methadone, or such as the other narcotics like oxycodone, will. And in particular, it doesn't stimulate and have the same CNS effects, so it doesn't tend to cause the same euphoria and alteration in sensorium. And it also does not have the same level of respiratory depression, which makes this medication ideal for those two reasons. This is approved to be dispensed in the outpatient setting in people that have specialized licenses. Mostly, if you look at the literature, buprenorphine was compared to methadone, because at the time that buprenorphine was approved, methadone was the standard of care. And so we know that buprenorphine has the same efficacy as methadone in doses of 16 milligrams or greater. And it's approved right now for up to 32 milligrams a day usage in the outpatient setting. Even at doses of as low as 2 milligrams, which is sort of what we call those, homeopathic doses of medication, it has greater treatment retention versus placebo. And we know that it reduces mortality by up to 20 to 30% compared to placebo. How does this compare to other chronic diseases out there in terms of treatment efficacy? Again, I chose to focus on opioid replacement therapy for the purposes of this comparison. But we know that we have medical therapies that are incredibly beneficial for opioid use disorders and they have good mortality data. Well, we also know that in other chronic medical conditions, we have medications that have great mortality data, like metformin for type 2 diabetes. But what about other very common medications that we prescribe? Do we know a lot about the mortality benefit behind there? Last night, my husband sort of was like, no, you can't be right about that first one. If you look at the data, so insulin has no long-term mortality benefit for type 2 diabetes is the caveat here. Obviously, in type 1, this is a very important medication. But if you look at type 2 diabetes, and I swear, go to the literature and look it up, you can fact check me. It actually has no long-term mortality benefit. But how often do we prescribe this medication? And almost think of it as sort of our standard of care when it comes to type 2 diabetics. The main outcome they've showed in studies is that it only serves to reduce hemoglobin A1C. So I think probably more aptly, insulin treats the provider than the patient and treats provider anxiety when it comes to high hemoglobin A1Cs. Patients with no history of heart disease, statins have no mortality benefit. But if you actually look at the literature, we're now looking more into the possible relationship with diabetes and statins. And if you go and look, they actually will report a number needed to harm of 1 in 50 for people to develop diabetes. And if you look at the numbers needed to treat for aspirin, to prevent 1 death from a first-time heart attack or stroke, obviously, again, no history of heart disease, the number needed to treat is over 1,600 people. These are not exactly apples to apples, because several of the examples here are for primary prevention, not necessarily for treatment. But I wanted to use these examples to highlight an important point. I think, unfortunately, sometimes we're busy. New treatments come out, new recommendations. We don't always have the time to investigate for ourselves. But unfortunately, I think that there tends to sometimes be a medical dogma associated with certain medications or certain standards of care, whether that's a positive or a negative. And we don't necessarily investigate for ourselves. And I think, unfortunately, this negative stigma was attached to medications for opioid replacement therapy from day one. And unfortunately, that stigma has probably prevented a lot of us from really investigating these thoroughly and looking into the literature. And so this is something I wanted to highlight, that these medications are actually quite effective for treating opioid use disorders. And the last one here, right? And this again is focusing on opioid replacement therapy, because these are the medications that when I talk to providers, they most often would cite as being the most anxiety provoking. We worry about safety concerns, and then of course we worry about drug diversion. These medications themselves are a form of an opioid. Unfortunately, we do know that drug diversion does happen in these programs. And so these numbers were for buprenorphine specifically. The numbers are similar if you look at the data for methadone clinics. Surprisingly, because methadone usually is administered with somebody watching, but people are still able to divert their medications. So the incidence is somewhere between 18 to 28% if you look at it, different studies. So almost 30% of patients potentially could be diverting their medications. And definitely that's a concern that we take into account when treating these patients. But is this a unique issue? Is it only people with substance use disorders that are sharing their medications? And it turns out no. This is actually, again, a fairly common thing in the general population. 23% of people have ever admitted to sharing or giving a prescription to someone. 27% of people say that they have borrowed someone else's medications. The most common of these is allergy medications, so I think we can probably forgive people snorting their friends' Flonase. But pain relievers and antibiotics are also on that list. And we know that sharing antibiotics can also have significant concerns. If you look in the US, less than 3% of people that present to treatment have a primary buprenorphine use disorder. So even though this medication is getting diverted, it doesn't seem to be getting diverted for the purposes of, what we think to get high. And 75% of people who do misuse buprenorphine or use a medication that has not been prescribed to them report that they do it in order to treat their own substance use disorder. So to try to stay abstinent from using other drugs or to prevent withdrawals. Safety is a big thing. So if you look at the data here, over an 11-year period, there were less than 500 deaths linked to buprenorphine use. During that same period, there were over 1.5 million patient treatment years. That's pretty good safety data in my mind. And if you look at the literature as well, most, if not all of the deaths were related to polysubstance use. And almost all of that polysubstance use was related to use of benzodiazepines along with buprenorphine. Some sources that you look at will actually refute the fact that buprenorphine has been the primary drug in any accidental overdose death. And mortality, and this is something that I think really should be a take-home point for people here. Mortality in non-treated individuals is astronomically higher than patients that are taking medications for opioid replacement therapy. And that mortality is highest among IV heroin users. And then treatment with buprenorphine is actually associated with higher survival and is a positive prognostic indicator. I chose this example to be a little bit kind of cheeky here, specifically because this graph is looking at one of our other most commonly prescribed medications in this country right now, unfortunately, which are synthetic opioids. This is only in 2016, there were 20,000 deaths alone. So it's 43 times more deaths in a single year with commonly prescribed opioids than in 11 years of prescribing buprenorphine. If you look here, I like this graph too because you guys can also see that the safety profile for methadone is not quite as good as buprenorphine because this is a full opioid agonist as opposed to buprenorphine's mechanism of action. If we know that these medications are safe and effective, why is it hard for patients to obtain them? If you look at opioid prescribing practices, so opioids are Schedule II medications, yet you don't need a special license to prescribe them, you don't need extra training, and these medications are often given out on a second or third visit. And there's virtually no prescribing limits. If you look at buprenorphine, it's a Schedule III medication. I don't know if most people are aware of that. But I had to pay a fee to obtain a special license to prescribe this medication. Mostly I had to pay the fee because I didn't know as a resident you could actually get it done for free, which I know now, thanks Dallas. But other providers that are not residents have to pay for this. And that's not an incentive to have to pay in order to be able to prescribe a medication that is already highly stigmatized. There are also a lot of prior authorization caveats. And I oftentimes have to continually fill out prior authorizations for my patients. There are dosage limits applied, and not even dosage limits. There are pill limits oftentimes applied to how many pills I can dispense at once to a patient. How many people have ever had an insurance company tell them that they couldn't prescribe the amount of synthetic opioids or narcotics they were trying to prescribe? It's a little bit of a strange disconnect in my mind. And another thing is that you don't need a special license to prescribe this medication for the treatment of pain, acute or chronic. But you do need a special license to treat this or to prescribe this to treat an opioid use disorder. And if you do not have the special license, you can actually be arrested for doing that. I think that this slide highlights that there are huge, huge ethical concerns when it comes to the system overall for treating patients with substance use disorder. And there's a huge violation of the ethical principle of justice. We certainly treat these patients differently than we treat other patients. And I think, again, we just need to recognize that and know that that's happening. I just loved this quote. I don't know if anyone's familiar with Chelsea. She's a late night host and comedian. So this is a more recent quote. Okay, so after we talked about all that, what can we do? I had to put in the obligate picture of my dog because I don't have kids, so this is all I've got. So this was my dog after a really, really hard 9-mile hike, and you can see the look on her face. And I think oftentimes when treating addiction, this is a similar look that many of us have, but there are a lot of things that we can do as individuals and together. One thing I want to highlight that's important is that we can learn from other models of chronic diseases. In 1988, only 23% of people with hypertension were technically controlled. And a little less than 30 years later, that number more than doubled. And how did we do that? Well, we came together as a medical community and as a society and realized that hypertension has significant long-term effects. It causes cardiovascular disease, chronic kidney disease, leads to a lot of morbidity and mortality. So we raised public awareness. We came up with very defined treatment algorithms. They came up with the concept of nurse visits, so patients could come in for quick visits for blood pressure checks. That would save a cost to the patient, and it also decongested providers' visits so that they were opened up to other visit types. They did promotions of single pill combination therapies, and then people got regular feedback about how they were doing when it came to treating hypertension. And I think a model similar to this could easily be applied to addiction. So what can you do as an individual? I think the most important thing is don't panic. If you have a patient that comes in with a substance use disorder, or you screen and somebody comes up positive, acknowledge that panicked feeling that we all have, that feeling of, I don't know what to do with this, and just take a breath. It is very easy, and I think a lot more simple than we realize, to just take it step by step and address this chronic medical issue with someone the same way that we address other chronic medical issues. And don't forget to ask. It's our job to identify this. And what's particularly important about this is that when asking, you could identify someone that does not have a substance use disorder, but has unhealthy or hazardous use. And you can potentially prevent them from developing a substance use disorder. And I don't know about the rest of the primary care providers, but primary prevention is sort of what I live for. And I think that we all find a lot of satisfaction from that. Refer to treatment. How many people here by a show of hands know somebody in the community, aside from myself, that does addiction medicine treatment? A provider. It's pretty good. How many people here know the names of every endocrinologist in town? Or at least one endocrinologist in town? One pulmonologist in town? Right? A lot more hands are going up. We don't really know who's out there because, again, the addiction treatment system is very segregated from the rest of the healthcare system as a whole. So I would urge everyone to find out who those resources are and make sure that you know that those resources as well as you know everything else. Get extra training if you want. It doesn't have to be prescribing buprenorphine, but you can even get additional training on motivational interviewing, which is not only helpful for treating substance use disorders, but also a multitude of other chronic diseases. And then just change the way you talk about addiction. Start using some of the terms we talked about today, unhealthy use instead of misuse or abuse or problematic use. It may seem small, but a lot of those terms have a very negative connotation with them. And if they get perpetuated throughout a chart and patients have access now to their own charts, they can see these and they can continue to feel very stigmatized. And hopefully, if I did my job today, maybe in addition, you also will change the way that you guys think about addiction. We have time for some questions people have. Went a little bit over, but.
You knew I would ask you a question, didn't you?
Most of this presentation, I was asking myself, what would Dr. Kadri say?
Good, and I'm motivating you. So, I worked with a couple of people who were addicted to opiates. Mm-hmm. And I think we do the topic lots of injustice when we call it a disease. That's number one. Number two, I would refrain from using other chronic conditions to justify treating addiction. Because you mentioned type 1 diabetes. We know what type 1 diabetes is. We know what the mechanism is. We talk about primary prevention. We continue to lump all opiates in one class. People who abuse pentazocine do not have the same mortality as people who abuse OxyContin or heroin. And when we talk about, our approach to things. I'll tell you my experience. With time, you become burnt out, and you say, you know what? And I'm seeing you and you guys. There is a linear relationship. We become burnt out, and it really needs motivation to continue to invest in the patients. And as Ned said, we just don't have time to deal with these things. So, I mean, the most common condition we deal with in cardiovascular medicine is congestive heart failure. It's not a disease. Hypertension in itself, we have a metric. If you're interested, go to the New England. There is a fascinating article about the neurobiology of addiction. We simply do not know as much as we like to think we do. We don't. You talked about 100 years between the structure of cholesterol and the statins. Yeah, we're just starting to scratch the surface.
I completely respect your skepticism, Dr. Kadri. I think it is very important to have different viewpoints when we discuss topics like this, because I think it is easy for us to fall into simply staying in our own lane when it comes to thinking about things the way we do. And so I think that skepticism for sure is healthy. And what I simply wanted to highlight here was that we tend to think that there are more differences between addiction versus other chronic illnesses. And I actually think that the inverse is true. I wanted to highlight that while it may semantics, it may not be necessarily correct to call it a disease. Addiction has much more in common with other chronic illnesses than it doesn't have in common. And just briefly touching on when you mentioned time, there's a study I really wanted to present here, but I didn't have time to. So there's a new therapy out there called screening, brief intervention, and referral to treatment. And it's actually being studied right now by SAMHSA, and there are several grants. And so it showed that on average, if you employ this in your patient visits, more people get referred to treatment, and it adds 8 minutes to your visit time, which 8 minutes is 8 minutes, but I thought that was probably a lot less than most of us would think.
Cassie, I'm wondering about comments you might have about stigmatization of these disorders outside of our professions, meaning in the broader social context. And part of what I relate that to is 30 years ago, depression, I think, had a lot more stigmatization, which improved when more tolerated treatments, meaning SSRIs, came into our treatment toolbox. Thoughts about that?
I completely agree. And I actually think that substance use disorders and addiction are going to become the mental illness of sort of my generation in terms of medicine, is going to be kind of our crusade. Because now it is almost, I can't think of anyone here that would readily have a negative, talk freely in a negative way about mental illness. We're very conscious nowadays of how we stigmatize mental illness. And I think that you're right. I think a lot of that was public campaigning, public awareness, increasing public tolerance, because we're up against a lot historically. I mean, there were so many historical things leading to people stigmatizing mental illness. And the same is true. I wanted to present a whole section on the war against drugs in the 70s and 80s, but I didn't have time to do that. And so I think, just like I said, remembering the way that we talk about it sometimes is where that destigmatization starts. And hopefully, if we change our thought within the medical community, the rest of society will hopefully look to us and take their cue for how to treat substance use.
Hi, Dr. Lopez. I wanted to thank you for this very expansive and interesting presentation.
Thank you.
I wanted to ask, though, is there ever any studies about, does a patient stay on bupropion for indefinitely, or the same with methadone? Because I have some elderly people who are on methadone, and you're wondering, is there a reason to ever taper them and try something else? Or
that's a great question. And actually, there's not a consensus right now in the addiction community. In general, patients tend to be maintained on these for a year because the data seems to show that trying to taper them off before a year has worse outcomes. After a year, it really becomes up to patient and provider whether or not, and there are actually some proponents within the addiction medicine community that state that likely these will have to be lifelong treatments for people because they have such a profound alteration in their brain chemistry that it may just be unrealistic for them to never be on some sort of opioid replacement therapy. But yeah, still a lot more to come on that.
Can I just make one comment about the
Always.
methadone? So in the state of Washington, any physician can write for methadone. It doesn't have to come from a clinic. In fact, also in Texas.
Thank you. Learned something new.
Yeah, it's huge. I mean, oncologists write for it.
Oh, yeah, sorry. For the treatment of pain, you do not need to, the
Okay.
same as buprenorphine. For the treatment of a substance use disorder, methadone has to be dispensed out of a federally licensed facility.
And you might have misspoken, and I know you know
I
this,
did
but not all
misspeak.
opiates are class 2.
Yes. Thank you.
So,
This is true. We have a lot to learn from our patients.
so I think Dr. Forbes knows more about this than I do, but pentazocine used to be a medicine. It's an opiate, and guess what? It was a pill. They figured out a way to crush it, inject it. So they added what to it? Naloxone. So pentazocine isn't a class 2. Hydrocodone recently was moved from class 3 to tramadol, which is misconceived as a non-opiate. It's an opiate. It's not a class 2. So quite a few.
Thanks for correcting that, Dr. Kadri. Any additional questions? Thanks, guys.